announcements I just have a couple of announcements to start with, and then we'll go through some introductions. And then I have some things to share in regards to addressing health disparities. And then we are so blessed to have Yesenia Cruz from Providence Health. She's in a position of a health equity fellow. So I'm looking forward to having Yesenia share with us. We'll have some time for question and answer and then a brief evaluation at the end. So I'll go ahead and go on with the announcements. The main announcement that probably most of you who are working on the pilot know is the deadline is coming up for the first quarter reporting. That's coming up on April 30th. So hopefully that's going okay for you. And if not, please reach out so I can set up some time to help. I know that the first time around is always a little confusing and intimidating. So I've heard from a few people so far, but please reach out if you're having any trouble. And I guess we do have enough time. We can take, does anyone have any questions right now about reporting or any issues? Okay, hearing none, we will go ahead and move on. So for this afternoon's introductions, what I'd like to start with is having you introduce yourself first by saying hello in a language other than English, and then just saying your name and organization. When you start, then you can name the next person. We've been doing it like that. It's a little tricky, but I can try to help out if you aren't sure who hasn't talked yet. So I will start and I will introduce myself. I'll say hello of ahoy or dobry dan, which is actually, I was in the Czech Republic last summer and got to learn a few words in Czech. So I'm obviously working with Greater Health now. So I will go ahead and take it to Charlie.
Sorry, I missed the mute button. Aloha, my name is Charlie. I work as the clinic director for Pullman Family Medicine, which is part of Pullman Regional Hospital in Washington. And I will go to Olivia.
Well, hello everyone. My name is Olivia Barrera. Hola, or buenas tardes, as we say in different ways. I'm actually a nursing student getting my bachelor's degree through CBC, and I've gotten this great opportunity to be part of your guys' webinar today and see what kind of great opportunities you're doing in our community.
And Olivia, you'll pick who you'd like to go next.
Oh, I'm sorry. Let's do Michelle.
Hi, I'm Michelle Sullivan. Hola. I am with Yakima Neighborhood Health Services. And I think I saw Dan Ferguson on the call, so I'll go with Dan.
Arigato, Michelle. Konnichiwa, watashi wa Dan desu. I just said thanks, Michelle, and I said hello in Japanese, and I said my name is Dan Ferguson, and I will pass it to Becky. Becky Betts.
Hello, good afternoon. And you caught me too quickly. I'm trying to Google hello in another language. I'll say hi or wave. Maybe that'll do. Dan, you foiled me. I could have had the opportunity to look really intelligent. I'm Becky Betts, Chief Operating Officer of Greater Health Now, and I would not miss Yessie's presentation for anything. So thrilled that everyone's here and welcome. Oh, and I will pass it off to Ms. Kaylee Walsh.
Hello, hello in another language. Hola, I am Kaylee and I'm with Greater Health Now. And I will go ahead and pass it to Nicole. Did you already go?
I knew it. Knew you were gonna come for me.
Aloha. I covered many bases. I can't be as cool as Dan, but I do say hello and goodbye and love. Nicole Matthews with Greater Health Now, and I will go and pass it. Keep going this Greater Health Now train. I'll pass it to Maddie.
Ciao, my name is Maddie, and I am with Greater Health Now. And let's go ahead here. I saw Sharon's on here. So Sharon, what do you know?
Thank you, Maddie. Salam alaikum, everyone. That means hello, how are you in Farsi? And I am Sharon from Greater Health Now, and I will popcorn it over to, has everyone gone? Who is left? Let's see. Olivia, have you gone yet? Okay, how about Kayleen?
Hi, I am Kayleen Bai, and howdy would be my hello because I don't know another language. And I am with Pomeroy Medical Clinic here in Pomeroy, part of Garfield County Hospital District. And has Kim gone?
No, excuse me. No, I have not. And I can't show off any languages that I know, but I am going to say something I learned, and it doesn't mean hello, and I'll tell you what it means. I used to work with a lot of people from the Philippines, and they taught me to say Mihal Kita, which means I love you, which is kind of like hello. And anyway, my name's Kim Emery, and I'm the Director of Clinic Services at Columbia County Health System in Dayton. And I don't know where we are on all the people, so I'm gonna
How about
ask.
Stacy George?
Okay, how about Stacy?
Hola, buenos tardes. My name is Stacy George, and I am with Community Health of Central Washington. And I will pick Brian.
Hola, my name is Brian. I'm a community health liaison with Greater Health Now, and I will go with Norma. Well, seems that individual. How about Molly V?
Hi, I just popped on, so I missed the question. Hi, my name is Molly V. Providence. Was that the only question? I'm sorry.
You're okay, Molly. Just if you can say hello in another language.
Oh, Laura, we should have told her she needs to do her whole introduction in another language.
The only one I can think of is Ola. That's all.
Perfect. I like it.
Yeah.
And we haven't had Marcia yet.
Oh, ciao. I'm Marcia Baden. I also work at Garfield County Hospital District and Pomeroy Medical Clinic. I'm an RN and care coordinator. And I don't know who hasn't gone.
Okay, I'll pick up Kevin Taylor.
Hi, thank you. Yeah, it has me listed as XAV2580E, but that's okay. Jambo. Jambo is hello in Kenyan Swahili. And I'm medical director of clinics through Lord's Health in Pasco.
Great. And I think if there's anyone else, Norma, are you able to unmute and say hello?
Hello, I'm Norma Guzman, clinic manager at Lord's. I'm driving, so I'm sorry, but I do know how to say hello in Vietnamese. Xin chào. Me and my granddaughter, when we get our nails done, we learn a new word every time.
Thanks, Norma. Appreciate it. Okay, I think we got everyone. I'll just pause a moment. Did I miss anyone for introductions? Okay, that's great. For those of you who have just recently joined, Please make sure to go ahead and put your name and your organization in the chats. That's helped me keep track of who attended. I'm going to go ahead and move on. I wanted to highlight, so part of our primary care transformation model criteria pertaining to health equity. So yeah, as we are working to try and see how we can do with meeting these criteria, I wanted to mention some of them that are built in, and I am really pleased that these things are in our model and that we can be working towards them. So in the first area of accountability, culturally attuned care. So the second level, 8.2a, practice quality improvement strategies related to patient engagement include consideration for demographics. And then a third level, or three third level criteria, practice has a documented strategy to support having in the provider team compositions that reflect patient panel composition as informed by race and ethnicity data. And then another one is practices train staff on culturally appropriate care. And then practices partner with local culturally attuned community-based organizations to help understand and participate in addressing the community's health-related needs. And then for accountability 9, health literacy, I didn't put, there's one on each level at least, and they all pertain, but particularly that the practice has patient-facing materials and forms that are at the appropriate level for reading and in languages that reflect the patient population. And then another one from accountability 10 is 10.3f. The practice can stratify analysis by different demographics and appropriate patient characteristics to support efforts to improve health equity. So as we can see, the team of providers that worked with the healthcare authority to come up with the criteria for this model, we're thinking about health equity and thinking about culturally appropriate care. So just wanted to kind of tune that in, and some of the things you'll hear today might help you give ideas, help to give you ideas on how you may address these criteria and be able to meet them for your assessments. So I think it's just important to think about why even do this work? Because again, you know, we've done, some of you who've been working on practice transformation for a number of years have been working hard to do some of this, these individual efforts, but now, you know, this one comes in, and I think much in the same way as when we even started to try to look at screening for social determinants of health back in the other transformation work. Now we're looking not only at that, but you know, looking at the community as a whole, and then trying to look at disparities of care, that how we can improve those. So why? And one of the things is state requirements. So I recently attended the NCQA Health Equity Forum in Los Angeles at the beginning of March, and I learned so much. California is really a lot farther down the road than us on this, and the laws and the requirements of the state Medicaid agencies are also they're in place there. So they've really done a lot of work, a lot of alignment even with all payers, not just Medicaid managed care organizations, to begin doing this work. So it was fun because I got to hear a little bit what it's like to find out after you've been implementing these things, the wins that you gain overall for your organization. And the one that comes to mind is the second bullet point, is how it advances the quality improvement efforts that we've been trying to do sometimes for many years. For instance, gap closure, you know, the one A1 that comes to mind is one that I was recently talking with Lourdes about when I met with them. They're looking at, okay, well, let's, you know, we're going to see about doing a quality improvement goal. They've done it in the past, but looking at maybe potentially a little bit different on hemoglobin A1C greater than 9%. But I challenged them. I said, well, what if you do have the data, you know, on your demographic data for race, ethnicity, sexual orientation, and gender identity, and some parts of it. What if you just, when you pulled that data for your patient population, if you went ahead and took those slices out just to see if there's a disparity there? So what is the stories that I heard at the NCQA conference were that when that happened, they started to see real gains. When you notice a disparity with a particular population, and then you begin to work on that by looking at, well, what are the barriers? You know, what is it with this group that is it language? Is it culture? Are we missing them? You know, we do these big campaigns where we're sending out texts or emails to say, oh, you're missing your mammogram, or you need to do colorectal screening, but these people are never responding, and we just don't see those gaps closing. But if you look at just even a small slice of the patient population and try to address some of those barriers in very creative ways, then you start to see, oh, okay, it might even apply beyond that individual population to the larger population, and they started seeing gap closures. So in some places, they had very separate committees to work, or individuals working on addressing health inequities and quality improvement, but not very far down the road, pretty soon it was all integrated. And where they met separately, pretty soon they were meeting together quarterly, and then they're just, we're just all going to meet together. So that was a really fun thing to hear about, having myself worked on trying to close gaps on some of these quality metrics for healthcare, and just feeling so frustrated because it's like, how do you do it? I don't know. So that's just something I'll hold out, you know, as you hear our discussions today, to think about why, you know, and last of all, it's because it matters. I mean, really, during the pandemic, we learned of some pretty telling data that had really caught our attention. I really appreciated, even though it was hard to hear about, you know, why some people were hesitant to get vaccination. Some people couldn't, even if they wanted to, all kinds of things. It really was eye-opening. So I think that was kind of, for some organizations, a hallmark opportunity to begin looking at addressing some of the health inequities that we're seeing. And you know, it's just heartwarming to see when there's progress made and you see these populations served and their health improving. So I think it's all quite exciting. And I will go ahead and share a couple of more specific, few more specific things on how to do this work. Initially, you know, just in preparation for your organization, is to establish a commitment. It's just like, you know, as an organization, we want to do this. This is something we're committed to. And leadership will need to lead the charge. You know, there will be decisions that need to be made, resources, staff positions, time, as far as allowing staff time, and committing to that beginning level of getting the data in. And it's not just as simple as asking a question, as we'll talk about it a little bit, but it is just an overall commitment, and leadership would need to lead the charge on that. Another important thing I think that helps get the language out there in the organization is to do self-assessment. There's a couple examples here that I'm giving. There's definitely more out there. There's a lot available to begin to think about, how do we assess our organization? Where are we at in regards to how we are addressing disparities in care? So the first one is a guide, and health equity guide from the CDC. And the next one is just talking about the NCQA health equity accreditation. So CDC has building organizational capacity to advance health equity. This is just one little piece. They've got a whole lot of literature, resources, all kinds of things on the website, talking about how you can get your organization to begin to address some health inequities. So this was just an example of an assessment that they had, and this one was really simple, but also I like simple. Those of you who work with me know I'm always saying that during our meetings. It's like, no, we want to keep it simple. So we're looking at where are we now, and there are questions underneath that. How can we institutionalize our organizational commitment to advance health equity? How can funding decisions advance our health equity efforts? How can we build a skilled and diverse workforce committed to health equity? And how can we integrate health equity into our products and service offerings? How can our partnerships and community outreach efforts help to advance health equity? And what are our next steps? So in the corner of this slide, and I will email the slide deck out after our time together today. And then it'll also be available on our website on greaterhealthnow.org. And you'll be able to listen to the recording of today's webinar, as well as look at the slides and have all of these resources that I'm going to give you. So the second little caveat that I wanted to cover with you is just the health equity accreditation process for NCQA. So for me, being a nurse and working in hospitals and healthcare, I kind of get scared when we say accreditation, or joint commission. It just feels like you're getting tested and questioned, and it's kind of scary. But I got to learn about how this health equity accreditation process goes with NCQA, and it's very much a hand holding. It's not scary. It's not like you sign up and then they come do their survey, but it's very much in consultation, and very much that they would help you do the initial assessment and help you with how to move forward. You get the gap analysis for comparing the standards from their organization to your organization. And then, the other steps are there. So I've given the website, and even there it said there's a little button you can click that you can call them. So they're not scary. They're really excited about this work. They want to advance this work in healthcare. I would just say, if you're thinking about it, or your organization is thinking about it, it seems like a very worthy effort, and you get a lot of help. So that would be great. I'm going to pause there and just see if anyone has any questions on that first section. Okay. So another aspect of beginning the work is how to do it is, of course, the first piece is collecting the data on race, ethnicity, language, and then sexual orientation and gender identity. So there's OMB categories, office management and budget categories. And then there's the Washington State requirement for hospitals. And I know some of you already are using those requirements with your EMRs. And then I have some more information on each of those topics, but I also just wanted to talk briefly about staff training for collecting the patient data. In my meetings with you, I know this has come up more than once. It's like, okay, it's on our front office staff really doesn't know how to even answer these questions. So some of the EMRs have the ability to gather this demographic information, but we don't have any real staff training on it. So it is very important to have some staff training, and I do have a couple resources for you today to turn to help with that. There is an importance for the way that you gather I'm going to say REAL for race, ethnicity, and language, and SOGI for sexual orientation, gender identity. So there is an importance for having that data be self-reported by the individual. Since a lot of the payers now are being required to, in different states, to gather this information and report on how they're addressing health disparities. They are getting information from lots of different places and then bringing the data into like a central data repository. And then sometimes it's hard to find the truth because it may be reported differently depending on what they're bringing in. So the gold standard here is self-reported data by our patients. And so that's happening in some of the organizations already. So an example is by having the patient fill out this information prior to a patient visit, and it's done electronically or when they arrive to be able to answer the question. So that's great, that we in the clinic settings have this opportunity to get the information right from how that individual identifies with this demographic data. And the other thing is very important and is for the patient to have an opportunity to decline. Very important as an option. We don't want people to feel uncomfortable or pressured, and they need the option to not. For people to feel comfortable and wanting and able to offer their demographic information, there needs to be this relationship of trust. So some of the resources that I'm going to share with you really build on that, on how do you do that with helping people to feel comfortable reporting this demographic data. And it's important for them to understand how you're using it. So how we want to look at this to provide better care for all of our patients. And some groups are sometimes not receiving information the way we'd hoped. So this is an example of an explanation. But when we look at the resources here in the next few slides, you'll see some help that you can have for your organization to try to get some of this training done and some of these discussions happening with your staff. So the OMB standards, they were just revised. So in the 28th of March, and that's, I think it was a long time since they were before, I think maybe 1997. So now there will be one combined question for race and ethnicity instead of two. There was one for race and one for ethnicity. And they added a Middle Eastern or North African as a new minimum category. Why is this important? Why the OMB? It's because the federal entities are required to use this standard for programs that collect or use race and ethnicity data. And it's hopeful, it's like that apples to apples thing, that everybody's gathering at the same, so that when we share information, data, that we are having the same definitions and same categories. So there's a link there to an article that I found very helpful about this latest revision. So it's there for you guys to access. So the Washington State Legislature passed the new hospital data reporting requirements in 2021, and there's the RCW and WAC for that. There's a resource that I've given you a link to here below. So happy to see that. There were several good resources within this at this website in regards to patient education, the definitions of demographic terms. I know that's come up in some of the conversations with sites. It's like, what do they mean by these different categories? Because there are definitely more categories than the OMB basic ones in this requirement. There's staff training, patient feedback, and then there's some FAQs on this website. So there's your link, and I hope that you check it out and see there's lots and lots of resources there listed. And that website is from the Washington State Hospital Association. So good information. The staff training resources, particularly there was one that I saw from the Department of Health, and it had some really nice verbiage on collecting new patient data, just helpful, plainly stated information on why we're doing it. That would be really helpful to incorporate in any scripting that you might put in place for your staff that are helping patients get this information to us. So take a look at that. I've given the link there. And then the AMA had a module for your practice, for the training module, that had little cartoon scenarios on how not to ask for this demographic information and how to and why. So it's very, very simple, but I liked it. So I've put this link for you to be able to access that training. And with it, I don't belong to the AMA, but they have you can still use the resources by just creating a free account. So it's still possible even if you don't have a membership. Okay, I'm going to pause again if there's anyone who has questions. Okay. So the last part of how to do this work, very important. And I know my friends from Greater Health Now are going to be excited that this is here, but community integration, sharing what you're doing across the community. As we know, these trying to address these health disparities deal with upstream community-wide things that we need to do. So when we're really working hard and seeing some wins on this work, it's so important to share what we're doing across the community, because no one organization can do it. It does require the whole community to address some of the issues, food, transportation, housing. It can't be done just by one organization. We're working together here to improve healthcare for our community. And then also partnering with community-based organizations. So having staff on boards or being on community-wide boards. We're looking forward to the work that Greater Health Now is doing and having a community hub for community-based organizations and resources. So all of that is just really great work that's being done that will help us better serve our patients and each individual population. Anyone from, I will open up for a moment for anyone from Greater Health Now who wants to speak to this.
Hi, Laurel, this is Becky. I just reiterate, yeah, this is such an important part of Waiver 2.0. You know, health equity components and those screening guidelines are baked in nearly every page. So I think this is just the tip of an iceberg. And in a time where we may feel a little fatigued, but I recognize the importance of such, there's only going to be more coming. So, and this is hard. This is a, you know, we recognize this is sometimes a real admin burden on clinics and hospitals and figuring out our way. But I think we can partner together and improve a better system for sure.
Okay. And as you know, those of you who've been working on the model for your transformation efforts, partnering with community organizations are part of the third level and most of the accountabilities, the third level criteria to be partnering with community-based organizations. So exciting stuff. Okay, so I am very excited. I would like to have Yesenia Cruz go ahead and open up her, I hope you have your camera on already, Yessie.
Yes,
Good, okay. So Yessie is a health equity coordinator for Cadlick and has been with Cadlick since 2010. She started her career as a medical assistant and also worked as a front office assistant, referral coordinator, surgeon and surgery scheduling, and is currently a clinical care coordinator. She's also has experience as a community health worker. So she's a fellow for Providence's first Health Equity Fellowship, and she is a proud first generation Mexicana and is passionate about health equity work. So I have so enjoyed getting to know her in preparation for our webinar today, and I will open it up. Yessie, if you want to talk a little bit about yourself and also tell us about the Providence Health Equity Fellowship that you're doing.
Yes, of course, and thank you for the opportunity to present today. So yes, I'm Yessie, and just like she said, I've been with the organization Cadlick or Providence for 14 years, and I was very excited to given the opportunity to be a fellow for the first cohort of Health Equity Fellowship. And what that entails is a 12-month program, is a 12-month of curriculum to help build capacity within our organization to continue our health equity efforts here with Providence, and also obviously our community, because we partner with a lot of community partners, and learning best practices and how to align our initiatives to continue the health equity efforts, and also federal requirements under the Centers for Medicare and Medicaid Services, and of course the Joint Commission. So it's been a huge learning and experience, as well as building even personal capacity to be able to be more valuable to the organization and the community to continue the health equity work.
Okay, thanks, Yessie. So if you could share with us about some of the work that you're currently doing to address health disparities.
Yeah, so we do have hypertension within our BIPOC population to address those health inequities that exist within hypertension. We also have our trauma support program that is primarily with our Latinx population to address trauma and mental health. And so those are our two main things that I'm currently working on here at Providence to address health disparities.
Okay, and I know that it was, I guess, some of the sites listening with us might go, oh, well, how did you ever get started? So do you have anything that you can share with how you began to do this work?
Yeah, and I think it's kind of hard to say since I don't know, like, it was just, we're part of Providence. It's an initiative within all Providence, within all their ministries and regions. And so as an organization, it's a promise to all of the different communities that they have hospitals in to address the healthcare with a health equity lens. And so we were given the task to look at our community we have right now that we live in, and is there disparities that we can work, to close some of those gaps. And because Catholic is a level 2 trauma center, it really brought up that opportunity because they were looking at that information. They said, oh, there is a disparity or inequity between the Latinx population and the majority population in regards to trauma. And so really that's where the trauma support program was started, or where it was born, of needing to have something to, have a health equity lens to be able to address those trauma patients that were coming into our hospital.
Thanks, Yessie. So I think one of the things is Providence has access to data and reports, probably too much sometimes. It's hard to choose which one to look at. But some of our clinics that are trying to do this work or thinking about it don't have those kinds of that type of information, data pull that they can do. Do you have any recommendations or suggestions for them?
Yeah, of course. I know that part of, just our investigation being the first step is like doing an analysis of where are we at, right? And as an organization, where are we at? What are the needs of the community? And so I would recommend to look at even Washington State, like for example, for the trauma support program, we looked at the Washington State traffic commission data and looked and saw, wow, not only are we seeing it here in the hospital, but they also have some information that from the traffic safety commission that really just validated everything that we're seeing. So looking in your communities, what other organizations are also, what are they doing? Can you join forces? Are you seeing something within your patients that it's like a trend or a common denominator that you can look at and see what Washington State is doing? I think that would be one of my advice if you're starting, of really looking what the community is currently doing.
And we also, yes, he shared with me, some of the beginning information that she had. And I just was so taken back. I was like, yay, Kim from Columbia County. I know, sometimes we have these challenges. We're like, how are you going to get that data? And it's just so hard. So I would say, there's some other sources of data that with, some real innovation and creativity that you might be able to access to start to look at what's going on in your community-wide. And then if possible, try to pull data from your EMR, your organization, to see if it is also obvious in confirming of that within the data that you do have available. So that's just very, very hopeful to me, because I do understand it is so hard to try to know where to start. And if you don't have data, you can't just say it's better. But I know, Yessie, one of our conversations we were talking about was, I guess we'll get to it when we look at the line graph, but can you speak to sharing stories about what you're seeing, not just looking at, because sometimes that outcome data is slow, to see, changes that really seem statistically significant. Would you mind speaking to that a little bit?
Yeah, we were talking about how important it is to have data, right? We know that. And I really appreciate all of the resources that you shared in regards to collecting a lot of, the race and ethnicity. All that information is really important. And then because that's going to drive us and tell us where we need to go. But also when we're doing the work, this is hard work, and it's work that it might not give, the data might not move as quickly as we want. So another thing that we quickly learned is that it's also important to keep those patient stories in front of us and those outcomes, because maybe the data is moving very slow, but those outcomes and building those community partners, building that community trust within, the patients that we're helping is huge. And we know that maybe a lot of it, we are talking about social determinants of health, and that it takes more than one organization to be able to help one patient, to be able to, close a gap, right? And so I think that having those patient stories and those outcomes are really important to keep in front of us, to help us move forward and not give us like when we're getting fatigued looking at those outcomes, to keep us moving forward and not want to not give up is not the right word, but just to keep going.
Yeah, and it's okay if you don't, but is there any story that comes to mind through this work with the Latinx community that you would be able to share?
Yeah, there is quite a bit of stories within the trauma support program, but one story that really stays with me is a 21-year-old that had an agriculture accident at work, and he was very injured. He did not have legal status, and so our trauma support specialist, she focused on the mental health part, and our community health worker really was there to support him in regards to the social determinants of health, and be able to just be a support to him of going to appointments, making, L&I was involved, so helping him through all of that process, and then building that trust to give him the empowerment that he needed to advocate for himself, and also to get a lawyer involved to be able to help with his case. And I just think how amazing that he was able to get empowered, because that's what we want, right? We want to empower our patients so that if one day, we're not able to be there for them, but they feel empowered to, advocate for themselves. And he has been doing great. He has a lawyer and his case is going, but I mean, if we weren't there, he might have not gotten a lawyer. He might have thought, oh, I'm going to get deported, or I'm not going to be able to get a job anymore. And so just being there to support him it's been huge. And we always think about stories like that when we feel like, oh, we outreach to a patient and they don't want to be part of the program, or like, oh, when we get to those hiccups, then we remember like, hey, we have this patient and he's doing great, and he was able to get empowered and help him close some of those social determinants of health barriers that he had. And it's just very, very inspiring.
Thanks, Yessie. And another thing I thought of when we were talking about individual patient stories is, for instance, this story that Yessie just shared is that it's hard to build trust in communities. And as you have a story like that individual would be able to share his story with other people to say, maybe at the beginning it's like, oh, you can trust this named community health worker, or you can trust this, you know, and that could be like, no, they serve me well. I would suggest you reach out to them. So that word of mouth and that spreading within some of these pockets of cultures and people that have very little trust with our healthcare system. I think those are not as measurable, but so important, and it really does spread. So I just love hearing the stories, and I'm sure other people do as well, of how, you know, I think, you know, we've been doing it a while, but, you know, we need to just keep those in mind and keep pressing on to try to close some of these gaps, you know, that are indicative of, you know, years and years of, you know, systemic issues with health disparities and inequities. So we don't even know, we can't think of the ways to address them. You know, we just have to keep trying, and then hopefully through creativity, thinking outside of the box, and having people that are closest to that culture, we can help to begin to see some wins on this work. So Yessie, what are some of the tools you've used to assist you in your work?
Yeah, so within the fellowship, I've learned how to do a fishbone and how to do a our fishbone. That tool, it really helped us to really see what were some of the barriers. And of course, maybe we would not be able to address all of those barriers within the program, but at least we would be able to understand which barriers we were going to be facing, and then try to find like avenues of how we were going to navigate through them. And so that really helped me and my team to say, when we have a patient and we're struggling looking at this, and then really helping us think outside the box to be able to help and be able to address the problem, which we know is, you know, the mental health part of our Latinx community. There's a huge stigma, and I obviously represent, I'm a Mexicana, so I know for sure I have family members too that till this day they think depression is not real. And so there's a lot of things that we you know, that we face as a healthcare system to try to help. And because we see that, you know, if they're not screening, but when they are screened, the numbers are really high. And so we want to be able to address it. And so having a tool like this really just help us just really have a whole picture of how we're going to address it and how to navigate through it. And then we also have a process map, which, you know, really just outlined our work and how we were going to work through that within our trauma support program. We run reports to look at those trauma patients that come into the hospital, and then, you know, we outreach to them and we tell them the benefit of being part of the trauma support program. We follow them for 6 months, and through those 6 months, they have a trauma support specialist that can do early interventions depending on the PHQ scores, and then a community health worker to be able to address some of those social determinants of health. And then we don't just graduate them at the 6 months, we support them in making sure that if they need more than 6 months of support, that we can refer them out to our community partners to continue having, whether it is mental health support or any other you know, social connections of any way that we can use our community organizations to be able to support them that way.
Okay.
And then our PDSAs, I'm sure all of them know them here. And I know there's different formats. This was just the one I've learned and within my fellowship. But this one is the first one we created in regards to our scripting and how we were approaching our patients. Again, knowing that our Latinx population has a huge stigma in regards to mental health, we learned very quickly that we needed to change our scripting. And again, having them understand the support that we can give them, the benefit for them. And once they saw and we built that relationship of that, helping them navigate through those social determinants of health barriers that they had, then we can concentrate and look on the mental health part, where they will be a little bit more agreeable. It's like, hey, I'm helping you with, you can trust us, we're helping you with your bill, or we're helping you with transportation, or we're helping you to get a primary care, and we also care about this traumatic event. We know that it can emotionally, mentally can affect you. We want to help you. Can we screen you, and can we look, and how can we, the trauma support specialists, give those interventions to be able to help them overcome that trauma and not have long-term effects like, PTSD and other things, to be able to empower them to be able to, heal through that journey.
Thanks, Jessie. So I'm going to just pivot back a little bit to the primary care transformation model. And again, those of you who are doing your reporting, you know that it's asked you, okay, so do you use any method for quality improvement, such as a PDSA cycle? So all you have to do is upload a document just like this to show me that you're doing it, and we'll know that you have competency in that. So and then of course, the workflows that show how the work is done. So we've got a great model here for some of the things that you might have in place at your organization, your clinics, that you can show competency for in the primary care transformation model. And then I just think, yes, this for the model, but obviously it just is a good approach to how to make some of these changes to improve care, not even pertaining to just addressing the health disparities, but these are just good tools to make you step back and look and go, okay, how can we even begin, especially on things that seem insurmountable? So just take out little chunks and use some of these tools to help you get an idea of where to start. And I love how Jessie says, okay, yeah, we can't do all of this, especially I'm looking at that fishbone diagram, but it helps like kind of get it all out there, and that you can have a place to start. So I just, when we were talking about this and she said, oh, look at this, Laurel, I was like, oh, can we show that, at our shared learning webinar? So I'm so grateful for Jessie and for Providence to be able to offer these points of how it's being done in our area. And here's another one.
Yeah, so this is a run chart in our data of since we started the program. We last in February was 1 year. And just a little bit of background, we have one trauma support specialist, MSW, and one community health worker doing this work. And as you can see, we've had lots of ups and downs, which is something you expect to see in a new program. And it's just, we're very proud about the work that they're doing, because again, the outcomes are more than what this graph can show you. Obviously, I only shared one story, but we have many, many stories of outcomes, and now the trust that we're building within the Latinx community and Providence is just, I'm really proud of it, again, because I represent that community, but also because this is just the first step of many programs to come that's going to help, my nieces and nephews, and, like me when I'm older, because I get care here too. So it's just really exciting to see that, that we're trying to, move the needle up and doing the right thing, which is to, provide care with a health equity lens.
Thanks, Jessie. So what are some key takeaways you would like to share with the group?
So first of all, for sure, I'm a community health worker at heart, and I love the community health workers. I think they've been a huge, it's been a critical role for the trauma support program. Also within our hypertension initiatives, the community health worker, can do so many things. I give kudos to all the community health workers, because it's hard work, it's important work, but they're very crucial. And then again, focusing on outcomes. Of course, our data is important, because that's going to move us and going to tell us if we need to pivot, but also just having our outcomes or stories those patient stories are important, and also integrating some of those stories to, if we need to change any of our processes or workflows that we have, can those patients help us move it so we can, if we're doing a good job, well, we need to do a better job, and those patients can help us, change that. And again, having that education within your organization, educating about what health equity is, why are we doing it, why is it important, collecting that data, all of the all the resources you that you shared about collecting race and ethnicity, sexual orientation, gender identity, all of those things, and that every single caregiver in your organization, whether they're front office, MA, RN, doctor, we all contribute into being able to have a health equity lens in our organizations, a health equity culture, which is what we want. And everybody here, we can all make a difference and be able to, practice healthcare with the health equity lens.
I love it. And any other thoughts you want to share regarding your work of addressing health disparities?
Yeah, I think that another thing, and we talked about this, Laurel, was that I understand that not every organization might have the capacity to do a fellowship. Not everyone might be able, to have some of the resources that I'm grateful to have. But one of the things that I think would really help is look within your organization. Is there a caregiver that, is passionate? Because I'm telling you, and my core leader knows how passionate I am about this work, because, I myself and my family have experienced some of those disparity and inequities within the healthcare system. So I think you will be very grateful if you invest in those caregivers that want to grow, that want to move the needle with health equity. I think that if it's possible, I encourage you to invest in those caregivers, because not only they're going to do the work because it's important, but they're going to do it with their heart. And I think that's really important when you're doing this work.
Yes, I love it. And it's just been so fun, Yessie, to get to hear about this work that's being done right here in our community. And I hope it inspires clinics that are listening, that, okay, it's not really, just start somewhere, with anything really. And might not be the place you wanted to start. I think, stories that I've heard from Catholic is it was pretty rocky at the beginning. It was just like, we don't know how we're going to do this, and so that's the way it is. Those are some of the same stories that I heard in California at the NCQA Health Equity Conference. It's just, you just try. And it's just, but all of the stories that I've heard, I haven't heard anyone say that's a waste of time. I've only heard how beneficial it is to organizations. So, what a great opportunity we have. And hopefully, hearing Yessie talk about her stories firsthand, of actually, because I don't like it sometimes when it's all on paper and you hear this, oh, this great thing is happening, and you feel we'll never do it. I can remember feeling that way as a clinic director. I'm never going to be able to be like that. And that's not the point of these shared learning webinars. I try to have the clinics present, because it's like, no, it really can be done. And we really want you to just try. And it's better, I think you'll maybe see it's more inspiring and moving forward than you could imagine. So thank you. Okay, any questions? And while I'm opening up for questions, I would appreciate anyone, please complete the survey to give me some information about things that you would like to see in the future, or how this went for you, things that you would like to see differently if it needs to be for the shared learning webinars. And then while some of us are doing that, I'm going to open it up for questions. So myself or Yessie, please go ahead. Or comments. You can just also say that.
Fantastic job. Thank you to you both. what you're describing is tenacity, knowing that it's going to be hard, but going through anyway and persevering, know that you'll be faced with challenges and questions and new obstacles. But congratulations, yes, you just got to start. Thank you for your hard work.
Thanks, Nicole.
Thank you.
How about anybody from one of the clinics that's on, I don't know, Charlie or Stacy or Norma, Marcia, anybody? Okay. Well, we do appreciate it, and I will stop sharing here. And I just appreciate everybody who's attended today. And again, I'll send out the PowerPoint to you, and it will be available on Greater Health Now website. We really appreciate you being here. Hopefully everyone that's on has already put their name in the chat. And I will be able to give you some extra time in your day, I think. Oh, no, we're right at time. So, well, that's good. I thought it seemed short, but I do really enjoy talking about this, and I appreciate so much. Thank you, Yessie, for coming on. Okay. Thanks, everybody. Bye-bye.
Thank you.